Good afternoon. My name is Dr. Joseph Semien. I'm one of the newer obstetrician and gynecologists at the Lake Charles Memorial Hospital. Today, I will be talking about gestational diabetes, which is a very important complication that's associated in pregnancy. By the end of this presentation, there's a couple goals that I will attempt to accomplish. One is to understand what exactly is gestational diabetes, to become familiar with the risk factors and complications associated with gestational diabetes. This is both to the mother and the baby. And also become familiar with the screening process and the treatment for this disease condition, and to become familiar with several things that occur during your prenatal care, during labor and after delivery, and most importantly, become very well aware of the importance of your postpartum visit and your annual visits. So what is gestational diabetes? It's a condition that develops during pregnancy when the body is not able to make enough insulin. And insulin has an important function. It's formed by the pancreas, and what its function is to metabolize or break down carbohydrates and also fats. However, due to several hormones that are produced during pregnancy, this becomes sometimes problematic, causing what we call insulin resistance. A little background in the reason why gestational diabetes is so important is it is definitely one of the most common complications, medical complications in pregnancy. And it accounts for about 6 to 7% of pregnant women, meaning annually in the United States we see about 200,000 cases of gestational diabetes, of mothers that are affected with gestational diabetes. What becomes very important is understanding the risk factors in ways that women can eliminate or decrease some of these risk factors. In order to decrease risk factors, we have to first know what the risk factors are. One of the risk factors have to do with ethnicity. African Americans and Hispanics and Native Americans tend to have a higher rate of gestational diabetes. In essence, just like regular diabetes, those that you get at adulthood and in childhood, but mainly seen in adulthood, obesity plays an important factor with gestational diabetes. Usually what we look at is the BMI, basal metabolic index, and that is that of greater than 30. They tend to have a higher risk of gestational diabetes. Age does play a factor, and those that during pregnancy is 25 years or greater have an increased risk. And what we tend to see now is that pregnancy is very common, or becoming more common during the later part of your years. So that's expected that an increase in gestational diabetes will happen. Medical history is important, that when you speak with your doctor, that you give a real detailed medical history. What becomes extremely important is what happened during your previous pregnancy, so that a history of gestational diabetes, a strong family history of gestational or any form of diabetes, being it mother, father, sister, brother, steroid use, and that is steroids like patients that have asthma that uses steroids for their respiratory problems. And it's also important if you had a large baby previously, that of greater than 9 pounds, it does increase your risk for gestational diabetes. Last but not least, those that are currently pregnant with twins or greater, that also increases your risk. So though you have risks, one of the most important factors is what are the complications and why do we spend a lot of time trying to address those that are having problems with gestational diabetes. On the maternal side, we see that there's an increased risk of hypertension. Mothers have higher blood pressures. They can also be affected with something, a condition called preeclampsia, which is very common, becoming even more common in pregnancy. The old name was toxemia. Because of gestational diabetes, we see mothers tend to have a greater risk for a cesarean section. Some of the long-term effects from gestational diabetes, mainly because of large babies, you see a more prevalence or more women that's affected with vaginal and rectal tears. And the long-term effect is women, because of the larger babies, tend to have something that's called uterine and vaginal prolapse. This is when the organs, the uterus and the vagina begins to protrude out of the opening of the vagina. This can cause a long-term effect of urinary incontinence when mothers tend to have leakage when they cough, sneeze, and so forth. On the baby side, as previously stated, the babies tend to be bigger, greater than 9 pounds. They also experience something that's called shoulder dystocia. This is when the baby have trouble coming through the birth canal. The baby can get stuck. And as a result of the baby having difficulty coming through the canal, the baby can experience something of broken bones, mainly the clavicle or the humerus. This is the arm and the shoulder bone. Baby can also experience some respiratory problems, and this is because of metabolic effect of the high insulin or high glucose in the baby. The baby can also experience what we call low blood sugar, and this can sometimes require the baby to be admitted to the NICU, causing not only problems to the baby, but also problems, social problems to the mother. And last but not least is fetal death because of the increased glucose or sometimes the low level of glucose at birth. So how do we screen for this, and who do we screen, and when do we screen? There's two types of screening processes. One is early screening, being at the first office visit with your prenatal care. This is for those high-risk individuals, as what we spoke about earlier. And then there's a universal screening that is performed at between 24 and 28 weeks. And it's always important that since this is a universal screening time, it's important that you have approximately an additional hour to do the test so that you're not coming back for another exam. So how do we diagnose gestational diabetes? The most common used method is the two-step method, and it's been shown that you get better results with this method. There have been some suggestions of a one-step method. However, this is something that we are watching closely to look at the statistics about it to determine if it's going to be a good method to use. The two-step method is what I would talk about at this point. It's a 1 hour glucose, 50-gram glucose challenge, and this is the screening process. What's important about this is there's no need to fast. We tend to see that patients wonder if I ate some candy or some snacks before, would this change the results? And the answer to that is no. And what it is that you take a sample, you will go to the lab, they will give you sometimes an orange soda to drink. It's like a liquid. Even at some facilities, they give like a cola flavored soda to drink. And then 1 hour after that, they will draw some blood and get your blood glucose. If that is abnormal, and what we mean by abnormal, your doctor will have a specific value for his practice, whether it be between 130 to about 140. And that varies among the population that's at hand. And then if this is abnormal, you will do a 3-hour, 100-gram glucose tolerance test. This does require you to fast, and it requires evidently extra time. And what you would do is you drink a similar solution. They will monitor your blood sugar first for your fasting, and then 1 hour at each additional hour at your 1 hour, 2 hour, and 3 hour mark. As I discussed before, the other approach is the one-step approach, not commonly used as much. It's a 2-hour, 75-gram glucose tolerance test. The reason why many physicians don't use it because it over-diagnose gestational diabetes, which means it puts about 18% of the people to have abnormal results when it's really around 6 to 7, 8%. So what happens if you're diagnosed with gestational diabetes? What are you going to experience at that point in time? One thing your doctor will order is a diabetic or nutrition consult or nutritional educator who will help you in coming up with a solution for carb intakes and fat intakes. Keeping in mind that the goal is not to lose weight, never during pregnancy. It's only to have a better lifestyle, making sure that you eat correctly and have some form of exercise in it. Your doctor will also order a glucometer, which is a machine that is used to measure your blood glucose. Lancets is what we use which you would prick yourself with so that you can obtain the blood to place on the glucometer. And I think one of the most important things is your blood glucose logbook. You will need to check your blood glucose about 4 times a day. That's at fasting in 1 hour after each meal. And then they will have some normal values that we look for, and that's the goals to achieve. Whether you be your fasting at 95, your 1 hour after your meals of being about 140 or less. And if 2 hour after meals is instructed by your doctor, then it'll be a value of 120 or less. It has been shown that during pregnancy, the best way to eliminate some of the risk factors that's associated with gestational diabetes is doing a 1 hour after meal glucose monitoring. So after this, how do we treat it? That's a couple ways, depending on how abnormal that your readings are when you're checking it for those 4 consecutive times a day. One is nutrition and exercise. Keeping in mind, like I stated before, this is not for you to lose weight. It's instead just a way to decrease your carbohydrate intake, choose more what we call good carbs over bad carbs. Good carbs being your vegetables, your fruits, and multigrain bread, and your bad carbs is your cookies and chips that we tend to eat on. Exercise has been shown to be an important factor with helping you maintain a normal blood glucose. However, it is extremely important that you discuss this further with your physician before even considering the exercise part. There's several risk factors that will have you not being able to do exercise, such as history of preterm labor or so. Another way to help in the treatment of gestational diabetes is through oral medication by mouth. Glyburide and metformin has been used. This has been shown to be a good form of treatment. However, there are some slight things that we tend to look at before treating someone with oral medication. The other method is insulin, and this is important, and it's been shown time and time again to help in maintaining a normal blood glucose. And what's important about it is it does not cross what we call the membrane, so it does not go to the baby. Unlike there's some small indication that the oral medications could potentially go to the baby. So what happens to my baby? How do we monitor women with gestational diabetes and their babies? One thing that you will notice is that you're going to have more frequent prenatal visits, and this is important so we can help in maintaining that you have a good diet at hand, and also that your blood glucose is in a normal range. So it's important, very important, that you remember to bring your glucose log to every visit. Another thing that we do is something that's called a non-stress test. This is when you go in and they hook up monitors to your belly, and this is a way for us to monitor the heart rate of the baby and also the pattern of the heart rate. Sometimes your doctor will consider doing a repeated ultrasound in the late weeks of pregnancy, and the reason for this is this because mothers with gestational diabetes, mainly uncontrolled, have bigger babies. So this is a way of counseling from your physician to determine if vaginal delivery would be something for you to consider, or should he recommend some other form or cesarean section. And then the other thing you see, because if we start seeing that the baby is getting more or bigger than normal, we might even consider inducing you at an earlier time, sometimes between 38 and 39 weeks. But as we do know under several studies that a 39-week baby does do better than a 38-week baby. But because of the risk factors associated with uncontrolled diabetes, sometimes it is important that we induce earlier. So what can you do as the parent or the mother to help is to keep your blood glucose in those normal ranges, your fasting of 95 and your 1 hour after meals of 140 or less. What happens when you go into labor? Nothing really changes anything from if you didn't have gestational diabetes. You can still receive the same pain medication. You can still have an epidural. Those things you tend not to have a problem with. But the only thing different what your physician would do was have a close monitoring of your blood sugar. So you'll get more frequent pricks, probably like every 2 hours to 4 hours, depending on if you're in active labor meaning 6 centimeters or above, or not. Sometimes, but usually not seen with gestational diabetes, your doctor may or may not initiate you on insulin. Most of the time you don't see that though. Now after you deliver, you have about another 24 hours of those finger pricks. And this is a way for your doctor to look closely and try to catch if you have what we call an overt diabetes, meaning that you potentially had diabetes even before pregnancy, and you may need insulin or oral medications. But however, what we see in gestational diabetes, most of the time this is not the factor, and after you deliver, your blood glucose goes back to the normal range. As I stated previously, what becomes extremely important is what we do after everything is all said and done. And postpartum visit is extremely important. This is your opportunity to eliminate some of those risk factors that you associated with gestational diabetes. But most important, this is your opportunity to find out if gestational diabetes is something that you're going to be faced with for a while to come. Therefore, your doctor will order a 2-hour glucose tolerance test. This is that 75 milligram or 75 gram sugar test. And what we have seen, the reason for this is that 50% of women that have gestational diabetes during pregnancy will have diabetes type 2 at some point in their life. And 33% of patients that have gestational diabetes will have gestational diabetes in subsequent pregnancy. So that postpartum visit becomes extremely important. So, coming to a closing, what can we do to decrease these risks? And it becomes very important, extremely important. It was well woman exams, your yearly exams. This is because you had gestational diabetes previously. It is recommended that you do that 2-hour glucose tolerance test about every 3 years. Once again, to catch that early detection of diabetes, to eliminate some complications, not necessarily that's going to be associated with pregnancy, but associated with your long-term health. And if pregnancy in the future is something that you're deciding, preconception counseling is extremely important. This is not something that's seen a lot in the United States, about 50%, approaching 55% lately. Most pregnancies are unintended, which brings forward several risk factors, but preconception counseling can help and eliminate some of these risk factors. This is when your doctor can give you some important things you can do to eliminate the risk factors before even considering your next pregnancy. Any questions?